So Lorlatinib is a third generation ALK and ROS1 inhibitor. It's one of the more potent that is currently in development. It has been assessed through a phase 1 and a multi-arm phase 2. And today I present the results of one of the arm of the phase 2 dedicated to the patient with ROS1 rearranged NLCLC. 47 patients were treated in the cohort. The response rate overall was 36%, and the probability to be free of disease at 1 year is high. It means that mostly half of the patient was at 1 year, which is quite significant, because in this population, more than 70% of the patients receive prior crizotinib, meaning that the only option for these patients is chemotherapy. 53% of the patients had brain mets at baseline, and the response rate in the brain mets was 56%, which is quite elevated. The side effect of the compound is well known. It's mostly hypercholesterolemia, hypertriglyceridemia, edema, weight gain, peripheral neuropathy. All these adverse events are dose dependent, so few of them led to treatment discontinuation.
So in about a third of crizotinib-resistant cases, the tumors have acquired a secondary mutation within the ALK tyrosine kinase domain. This mutation, it can be one of many different mutations actually, and they likely confer resistance by causing steric interference with crizotinib binding. The most common resistance mutation in ALK is the gatekeeper mutation, which is L1198F. That's analogous to the EGFR gatekeeper mutation, T790M, but there are a lot of other mutations as well. Many of the next generation ALK inhibitors are able to still inhibit ALK even in the presence of these resistance mutations. So not only are they more potent than crizotinib against ALK, but they also are active even in the setting of the resistant mutation, and that's why we believe these drugs for some of the patients are so active. Now there are patients who don't have a resistance mutation. About 2/3 of our patients who relapse on crizotinib are not found to have a mutation, and yet those patients also respond well to the next generation ALK inhibitor. So it seems like all patients, when they relapse on crizotinib, or most patients, when they relapse on crizotinib, still have some dependency on ALK, and that's why they re-respond to a more potent ALK inhibitor.
I'm Dr. Alicia Sequist from the Massachusetts General Hospital Cancer Center in Boston, and I specialize in the treatment of lung cancer. Today we're going to talk about targeted therapies for lung cancer. Targeted therapies are also sometimes called precision medicines, or molecularly targeted drugs, or molecularly targeted therapies. In particular, today we're going to focus on a type of lung cancer targeted therapy called ALK inhibitors. Let's first discuss how targeted therapies work in general and how they differ from chemotherapy. Chemotherapies kill cells that are dividing and function on the principle that cancer cells are dividing more often or more rapidly than normal cells within the body. As researchers have learned more about the genetic changes or mutations that cause cancer to develop, they have been able to develop drugs that specifically recognize and hone in on features that only cancer cells have, like certain genetic mutations. In this way, the treatments can directly target cancer cells. One class of targeted cancer therapies that is currently available focuses on the anaplastic lymphoma kinase gene, or ALK, genetic mutation. These ALK-directed drugs, like many of our oral targeted cancer therapies, are a type of medication called tyrosine kinase inhibitors, also known as TKIs. Cancer cells often have protein receptors on their surface. I often describe these protein receptors to my patients as antennas that are on the outskirts of the cancer cell, receiving signal messages that can help direct the cancer cells to grow. When a cancer contains a specific and defining mutation or a change in its instruction manual, it then goes about its business in a defined and unique way, including by putting a certain type of antenna or receptor out there on its surface. We can then take advantage of this distinctive receptor being there to act like a beacon and direct the TKI drug where to go and which cells to kill. When the TKI drug gets to the antenna, it interferes with the signal that is sent, and the cancer stops growing. Targeted therapies that are TKIs work best when the correct match is made between the type of mutation within the cancer and the corresponding type of TKI. As mentioned earlier in this video, we will discuss a group of TKIs called ALK inhibitors. There are currently two marketed ALK inhibitors, or ALK TKIs. Crizotinib, or Xalkori, is approved for patients with metastatic non-small cell lung cancer who are ALK positive, and ceritinib, or Zycadia, is approved for patients with metastatic non-small cell lung cancer who have progressed on or can't tolerate crizotinib. In addition, many other ALK inhibitors are currently being studied in clinical trials. ALK inhibitors work by blocking the signals that the ALK protein receptor or antenna sends to grow and divide. Recall that the ALK protein does this only in cancers that have a type of DNA change called an ALK rearrangement. So that is why ALK TKIs work only in patients that are ALK positive on gene testing. ALK inhibitors are taken orally in pill form. Crizotinib is taken as a pill twice a day, with or without food. Ceritinib is taken as a pill once a day, and it should not be taken within 2 hours of a meal. Overall, these drugs are well tolerated with a few key side effects. The most common side effect that crizotinib causes is a minor and reversible change in vision. This includes trouble looking at light, blurred vision, double vision, seeing flashes of light, and new or increased floaters. These eye problems aren't usually troublesome enough for people to stop treatment, and they often fade over time. Other common side effects include nausea, diarrhea, vomiting, constipation, swelling of the hands or feet, and feeling tired. Low testosterone is one source of fatigue in ALK-positive patients being treated with crizotinib for their lung cancer. This can also lead to sexual dysfunction and depression for some. Hormone replacement therapy has been found to be an effective method of managing these side effects. Serious side effects of crizotinib may include liver problems, lung problems, and slow, fast, or otherwise abnormal heartbeats. The most common side effects of ceritinib include diarrhea, nausea, elevated liver blood tests, which can indicate liver damage, vomiting, abdominal pain, fatigue, decreased appetite, and constipation. Serious but rare side effects of ceritinib include liver problems and lung problems, as well as severe or long-running gastrointestinal issues. High blood sugar is more likely to be an issue for patients with diabetes or glucose intolerance. Slow, fast, or otherwise abnormal heartbeats have also been seen. One challenge of TKIs, including ALK inhibitors, is that patients with lung cancer who initially benefit from them eventually develop resistance to them. As a result, their lung cancer may grow or spread. This is known as acquired resistance. Cancer cells are clever enough to eventually find a way to bypass roadblocks so that they can survive. The genes within the cancer may even mutate further in order to overcome the effect of targeted drugs. Doctors and researchers are working to overcome resistance in tumors and to keep tyrosine kinase inhibitors effective against lung cancer for longer periods of time. The next generation of ALK inhibitors is being studied in clinical trials now. I hope that this video has provided you with a better understanding of tyrosine kinase inhibitors, in particular ALK inhibitors, and how they may apply to your treatment plan. Be sure to check back at longevity.org for updates and more information.
Every year, lung cancer causes over 1.5 million deaths worldwide. This is more than any other cancer. Approximately 85% of lung cancer cases are a type of lung cancer called non-small cell lung cancer. 5% of these cases are anaplastic lymphoma kinase-positive lung cancer. This is more commonly known as ALK-positive non-small cell lung cancer. ALK-positive non-small cell lung cancer is caused by a change in the DNA of the cells. This change is caused when the ALK gene and another gene combine or fuse. The most common fusion partner in ALK-positive non-small cell lung cancer is EML4. The combined ALK gene creates ALK fusion proteins. When the ALK fusion proteins combine into pairs, the protein is switched on. Once the protein is turned on, it begins signaling and sends messages in the cell. It will send signals at high frequency within the cell, which eventually lead to tumor growth. Normal ALK proteins cannot be switched on unless another molecule binds to them. However, in ALK-positive non-small cell lung cancer, the fused ALK protein pairs can turn themselves on, starting cell signaling processes. Messages in the cell are shared using 3 different signaling pathways. These pathways cause cancerous cells to divide, multiply, and survive. This process means that cancerous cells can multiply and grow to become tumors. To stop this growth process, a type of treatment called an ALK inhibitor can be used. ALK inhibitors for ALK-positive non-small cell lung cancer can function in different ways. Some ALK inhibitors are more specific than others, only targeting the ALK fusion protein, while some also inhibit other receptors. But how do ALK inhibitors work? ALK inhibitors bind to the protein pairs and stop them from switching on and signaling within the cell. With the signaling turned off by the ALK inhibitors, normal cell signaling processes can start again, stopping the multiplication of cancer cells and causing the cancer cells to die.
Patients who went on crizotinib, they respond nicely, but after a median duration about 10 to 12 months, almost every patient would develop resistance. Now, there's a diverse mechanism of resistance have been reported. We classify it as ALK related and non-ALK related. For the ALK related, there are two mechanisms. Possibly, there is actually the CNS central, meaning that the brain metastasis may progress due to the fact that the drug may not penetrate the brain as good as they like to be. The other possibility is the fact that there's what we call a gatekeeper mutation. There can be multiple area along the receptor area that they may have a single point mutation that changes the topology of the receptor in the binding pocket such that the crizotinib can no longer bind to this ATP binding pocket. As a result, it will lost the efficacy of the control of the cancer. Now, there's also other non-ACAR related, such as transformation into other cell type, phenotypically, or actually may even have been reported of EGFR mutation or KRAS mutation that occur after the usage of the crizotinib in this patient. Is what we call the CNS, the brain metastasis, as well as the gatekeeper mutations.
So we know that patients who are on effective drugs like crizotinib, at some point they will relapse. Their disease will progress through that therapy, and it is variable. We know some patients, unfortunately, even very early on, can have either no responses or very short-lived responses. Fortunately, that's a minority of our patients. Most patients are going to get several months of disease control, and as I mentioned earlier, even beyond a year. And there are even patients who can have several years of disease control. I and many physicians care for patients with many years of disease control with never receiving chemotherapy. But we know at some point patients will become resistant. And when that happens, it can be a challenging time for not only the patients, but the providers, because patients can kind of go downhill, so to speak, rather quickly, where they're doing well on a therapy for a while, really no symptoms of their cancer, and then all of a sudden they have symptoms of cancer, and so there's a bit of a rush to make an assessment of why that's occurring and what your next plan of care is going to be. Is it going to be moving on to another tyrosine kinase inhibitor targeting ALK, or is it going to be moving on to chemotherapy? And that period can be difficult for patients and providers in making the best decision for their patient in a timely manner. It's interesting that like all patients with lung cancer, there can be progressive disease in different parts of the body, but without rearranged lung cancer, we pay particular attention to the CNS, or the brain specifically, So we recognize that at least half of patients can have brain metastases at some point in their care. Often at baseline, when you're just diagnosing a patient, we do routine imaging of the brain anyway for advanced lung cancer at baseline, regardless of ALK status. But in our patients with ALK rearrangements, it's important not only to look at baseline, but at points beyond that. So in a serial fashion. We're not used to doing that. We're not used to routinely looking in the brain when patients are not having symptoms. But it is highly recommended, is the way I practice, to periodically look in the brain with MRI imaging at least, some form of imaging, even if that was CT, is going to be important to identify asymptomatic metastases, or in some cases where patients are having symptoms, more widespread metastases in the brain. It is a real problem for patients as their first sign of progression. We do look out for lung and bone and hepatic progression as well, but it's the CNS that sometimes can slip by physicians and family members even, and that's where patients can get in trouble by doctors not recognizing that early enough.